Welcome everybody to the second of the 2022 Developmental Disability Program Clinical and Research Rounds. Our guest speaker today is Dr. Jennifer McLean, and I am particularly intrigued by the title of her topic. So it's F words for child development, the ongoing need to swear for functioning and health. Oh, I'm desperately looking forward to this, Jennifer, because I've never heard you use such things. So, Jennifer, I think we've been very lucky to have Dr. McLean here at CPRI twice over the years. So Dr. McLean went to, did everything at McMaster University. So her undergraduate degree, undergraduate also? Mm-hmm. You really like Hamilton. So undergraduate degree, medical school, residency, and developmental pediatrics fellowship before coming to London, where she graced us at CPRI with her presence. Then, after 8 or 9 years, Dr. McLean moved to Ottawa, where she was the director of the Children's Treatment Center for a number of years, and then moved to Halifax at Dalhousie University before seeing the light and returning to CPRI. Jennifer is a former president of the Canadian Paediatrics Society, section on developmental pediatrics, and is a longtime member of the specialty committee in developmental pediatrics for the Royal College. I think that from a personal perspective, I think Jennifer's been a wonderful mentor and colleague, and is always available and always helpful, and has a tremendous way with kids. And I learn every time I work with her. So from a personal point of view, I can say that I think it's great that you're here, Jennifer, and I think everybody else does. But thank you for agreeing to speak with us today. And we are, I don't want to say we, because I'm not the royal family, but I am certainly intrigued to hear what you have to say today.
Right. Okay, I'll just say next if you're willing to do that.
Yep.
Okay, next, please. Okay, so what we're going to do today is understand some of the conceptual changes that happen in the field of health and disability. So that's one thing. Another thing we're going to do is look at the overview of what is called the International Classification of Functioning, Disability, and Health Framework, or the ICF, we call it. And what are these 6 F words for child development? We're going to take a look at the application of F words for a strength-based picture of the child, youth, and family. And I'm going to give you a whole bunch of information about where you can find F words tools and resources that are available free, and to support the use and application of F words in practice currently and in the future, because it's an evolving area and we're looking for input from everyone. And this is all based on the work of CanChild. So I hope by now most people have heard of that. And I'm going to explain that in a minute. So there's the website, and also the Mental Health Working Group of PONDA. And I'm going to explain that in a minute. Okay, next slide, please. Okay, that was my poll. So yourself, say, do I know what these F words are? And I'm not going to take a poll with this. Next one. Okay, so the F words for child development, they're words or concepts. It's a way for people to incorporate concepts into every aspect of clinical service, research and advocacy, children with developmental disabilities and their family. And this is the logo that's come out of CanChild, so just so you can see what that is. But next slide, I'm going to explain how it all started. So how did it all start? First of all, the title was The F Words in Childhood Disability. I swear this is how we should think. So both founding members of CanChild is Dr. Peter Rosenbaum, and then Dr. Gorter, and Adam McMaster. And I've had a wonderful opportunity over my career to work with them at different aspects in time. And so I'm working with them again. And in 2012, they published The F Words in Child Disability. The impact has been tremendous. They've had over 45,000 downloads, citations in literature, and it has been translated to 30 different languages. An array of tools and representations, the F words and concepts are free, as I said, on the CanChild website, and there have been numerous local international presentations. Dr. Peter Rosenbaum, in fact, just to give you a perspective, was my fellowship supervisor for my developmental fellowship. So it's been an enormous impact around the world of working with the group. Next slide. So what are the 6 F words? Well, here they are. You're going to look at them and go, well, that's basic. Yes, because we work with children and their families, so we think of these things. But this is not the way always we thought about things in terms of medicine or in developmental pediatrics. So 6 F words are the following: function, family, fitness, friends, fun, and the future. Originally, the F words were done in the context of what would call childhood disability, but over time they've become very much more broadly applicable. And so now we call them the F words. We don't call them the F words in child disability anymore, but now we call them the F words in child development. Next slide. So what are these words? Well, then they always make sense to most of us. We know what they are, but let's just talk about that a minute. So functioning. Well, for children, their work is play. I mean, that's what we expect them to do, play. It refers to what people do. It's not so much how things are done, that's how they're done, it's important. It doesn't matter what it looks like. It's, are you functioning? Okay. Family is very important for children, youth, and families. And obviously, this is an essential environment for children and youth. The older concepts dealt with the child only. Well, we know that's not helpful. And we know that family-centered services, research shows that engagement with the families is ultimately important. When sources are family-centered, parents can report better satisfaction, better mental health, and less stress. And also, the issue about collaboration for goals and therapy outcomes are improved when you're involving the essential environment of the child and youth. Fitness refers to both physical and mental well-being, and it's often a neglected aspect of childhood disability, unfortunately, but research shows that children with disabilities and chronic illness do much better when they have recreational opportunities. And oftentimes these are hard to get. Next slide. Next slide, please, Rob.
Yep, give me 1 second there, Jennifer. I don't know what I did actually.
It's okay.
I have lost sight of everything somehow.
You'll be fine.
And I don't know where you've gone to because I can't see my slides.
Okay, well, I can go on to the next slide anyways. So the next slide refers to the 3: fun, friends, and future. Well, fun includes the activities that people enjoy, as we all do. There's good evidence that children with disabilities have lower rates of participation than their able-bodied peers. Friends, it's very essential for social development. Friendships for children with disabilities are difficult. When they grow up together with other children or are part of the social milieu, they do much better. And of course, future is what life is all about.
I apologize. I've completely lost here. I don't know what I've done because I can see you quite well and I can see nothing else. Okay, here it is.
Oh, there you go. Okay.
There we go. Yeah.
Okay, so perfect. So CAN-CHILD. So CAN-CHILD as a collaboration with researchers, clinicians, and families, and that's important. They'll look at all aspects of that. It was formed in 1989. It was a Center for Child International Collaboration. Its main goal is knowledge transfer and the development of resources. Next slide. Their vision is generating knowledge and transforming lives. Next slide. So what is PONDA? PONDA stands for the Physicians of Ontario Neurodevelopmental Advocacy. So it's a volunteer network of physicians and psychologists, and the whole purpose is to advocate to optimize the well-being of individuals with neurodevelopmental needs in Ontario. And we're doing this by promoting evidence-informed policy and systems of care. So a lot of work at the grassroots level and a lot of work in terms of the political level. Next, if possible, and I don't know if this is going to work, I had a short video. Let's see if it actually comes up. It might not, I don't know. Just join, yeah. Should be okay, yeah. And at the bottom should be, yes. Thank you, Rob. Okay, just watch it. And so you can see a father out there. He has made something. He's out there on the ice. He's making it, filing it down, working on it, trying it out. At the window, a lady appears. The father then carries a young boy down to the frozen lake, puts him on his homemade apparatus. Child's a little nervous, gets him out Obviously, the mother watching, child's got a safety helmet on, and he's out on the ice. And it absolutely enjoys. So look at the smile from ear to ear. Wow, there's his wheelchair back at the house. So that's the true picture of participation. Okay. All right. Thank you, Rob. Can you get back to my slides?
Sorry, Jennifer, you can see that?
Yes, I can. Doing a great job. So just next slide, I think it will be fine. Yeah, wonderful. Okay. So we have all been trained in the past in what I would call the biomedical model. So in other words, you take a look at the person, you've got a couple of the diagnosis, and the diagnosis give you a treatment. So the focus is very much on diagnose, providing treatment. But as developmental pediatricians and as child and adolescent psychiatrists and all the people in this room, we know there are many other things that are important than just the diagnosis as treatment. So first of all, what are we all trying to do? Help children and youth to develop to their best ability, whatever that is. We have to ask ourselves, so what is health? So based on Huber in 2011, health is the ability to adapt and self-manage in the face of social, physical, and emotional challenges. And this is the tenement that we're going to hang on the F words on, because functioning can be evident, and that's no matter how or what it looks like. You don't need to do things in a nice, normal fashion, whatever that means, just being able to do them. So the next slide, please. The other issue about 21st century concepts of child development is development issues are not diseases. These children are not sick because they're development issues. They may have other issues that relate to organ systems that may cause them problems, but they're not sick. We have lots of diagnoses. I mean, look at them all up there, the whole alphabet soup of diagnoses. And some children have a whole lot of these, as we see. But again, these are just labels. And their labels were used to describe functional issues, and they're based on clinical diagnoses, not on whether you do an MRI, not whether you do a blood work test, like in other biomedical issues, but these are really describing functional issues, and that's how we diagnose them. But let's talk about diagnoses. Next step. Next slide, sorry. Okay, so you're okay. Then we try. Okay, yeah, you're fine. We try to fit everything into categories. How much time do we spend going, oh, do they fit into this diagnosis? Do they not fit into that diagnosis? And why do we do that? Because a lot of pressure on us as clinicians, if you have a diagnosis and you have a specific treatment, well, not really so. But a lot of funding agencies go by a specific diagnosis, specific treatment. And schools, unfortunately, to a great extent, how many times we heard parents say, they won't offer him any help at school until he gets a diagnosis. Well, diagnosis is not the be all end all. What we really need is a non-categorical approach. Not everybody fits into these nice little categories, and they shouldn't. And many development issues are actually common across many developmental diagnoses and often co-occurring with each other. And there's less precision with diagnosis because, again, they're based on the clinical symptomatology. Furthermore, within each diagnosis, there's quite a heterogeneous group of children in that. They're not all the same. For example, not all children with CP are the same. Of course not. There's a wide range. Not all children with ASD are the same. Of course not. There's a wide range. Next slide. What we need to be focusing on more is what can a child do rather than what they cannot do. And we need to look at a strength-based approach to talking about the child. How many times we hear people saying, oh, well, they're going to fix my child. Well, fixing, I mean, there was that whole, like I said, the concept to get the diagnosis, you get the right intervention. But do we really fix children? We don't cure the condition or fix most of the children, as one would do with a broken bone or something. That's not what we're doing. Also, what is the whole concept of normal? I mean, who really knows what normal really means? And what about disability? Treatments are not definitely specific to a diagnosis, but based on symptoms. And disability, any one of us could have a disability of something silly like, we're short of breath, or we're having a foot problem and the elevator's not working. Then we can't get up to our office on what floor, that would be a disability. So what does that really mean? So obviously we need a life course approach to child youth development, because our children and youth are making it into adulthood and doing well into adulthood. These childhood onset conditions continue into adulthood. Next slide. So what in the world was the International Classification of Function? Well, first of all, in 1980, the World Health Organization came up with the concept at the bottom of impairment. You have an impairment in a body structure that will lead to a disability. And a disability, if you didn't help in any way, would lead to a handicap. We've gone way past that. The International Classification of Function is a universal model. It's not just for people with disabilities, for all kinds of people. It looks at the whole person and their environment. It looks at what people can do, not just what they cannot do. And it's an interactive model, because the interaction between the person and their environment. Next slide. Putting the ICF into a pictorial model or pictorial framework would look like this. Okay. The neat part about it is participation is a very important part of the framework. As you can see, the words are neutral. They are not degrading in any way. And we need to pay particular attention to what we call the contextual factors, because environment and personal factors really determine how we're going to do. Environmental factors are our family, our social, our financial, our political issues. I mentioned some of those already. And personal issues, your gender, your age, your coping mechanisms, all those things become very important. And it connects the ideas about the health and health conditions. None of the concepts in each box, as you can see, is specific to any disease or condition, and all are interconnected. There's no hierarchy here. This leads us to what we work on, which is the next slide. The biopsychosocial model. So there are 6 domains, as you saw. They're all bidirectional, all interconnected. And we also know that changes in any domain will affect other domains. Okay, next slide. So what does the ICF, those 6 boxes refer to? Well, body structure and function. Well, that's the integral parts of the body, the organs, limbs, components, and the physiological functions of those body systems, okay? And includes the psychological functions. Activity, the ability to do a task or action by the individual. Participation, your ability to be involved in life situations. Next slide. These factors are very important. Environmental factors, we talked a little bit about them. So there's the physical, social, attitudinal environment in which people live and conduct their lives. There are so many barriers to people with abilities and disabilities that one could never even think about why they would be challenging nowadays. So we have to think about what those really are and why they're there. Personal factors becoming really important. No matter what you're talking about, your past experience really affects your current experience. Your own temperament, your coping mechanisms, all influence how disability is experienced by that individual. Next slide. So this is a fun and a memorable way to remember the ICF. You can see the health condition, the fitness, function, friendships, family factors, and fun. And of course, future becomes important, because the future is at every point in time how we look at children. Next slide. The F, this is putting the F words onto that ICF framework that I just saw. And you can see the ICF framework in the middle part: body structure, function, activity, participation, environmental, personal factors. Putting the F words on it, now we talk about fitness as the important part about body structure and functioning. That in terms of activity, function is the key thing. Participation, children need to have friends and be with friends, just like anybody else. We also think about the environmental factors, and who's that? Our family, no matter what the family means, extended family and all the family and community together. Personal factors, at the end of the day, fun is the key part. It's a holistic approach to child development and well-being, and a strength-based picture. So let's go to the next one. So what CanChild has done is tried to put together resources for parents, and they're all available on the CanChild website. For example, sitting down with your child or youth and putting together pictures of the things that what they do for these 6 F words becomes very important, and they're there. The materials and CanChild are being created by researchers, parents, and therapists working together. Next slide, sorry, for the tool. Okay, there's even agreements in terms of what a child can sit down with their parents and help parents do this, or parent can do this with their child, so they can give this information on to sports people, give information on to schools and any transition periods in life. Next one. As you can see, there's even goals, the sheets that's already prepared in each of the 6 F words. And that allows parents and families to sit down together and talk about what their goals for each of these areas are for their child and youth involvement when they're speaking to people like us. Next. Next slide, please. Okay, and children also, if they're able to draw and express themselves this way, can also put in each of the 6 F words what their ideas are. And then you can see this little 7-year-old here who talked about that she liked skipping, she liked talking to her friend, she liked having friendships with her friend and who it was, pictures of her family, and pictures of her going to her friend's house and having fun, and what the future, what she wants to be. And as you can see, she's a mother, she's got a baby in her belly, and she's happy and has a balloon. Next one. So the F words initially were put together on the ICF functioning framework as a way to look at how we can look at physical ability, disabilities. But we now know that it can be used for any issues. And a lot of work is now being done to look at the issue of how it relates to mental health. And so the next slide, we'll talk about that. So currently there's a collaboration between CanChild and PONDA with researchers, clinicians, and families, both adults and their children, school, and something called School Mental Health Ontario, which I'll tell you about in a minute, and community services. And we're working on the conceptualization of F words for mental health and well-being. Trying to formalize it to make it a little, so it's readily available for families and children to represent the holistic view of their child from the mental health perspective. So we did have a presentation at the PONDA annual meeting in May. We have an invited speaker on this topic for the CPRI education series in April, so that's coming up, and an invited speaker for the annual Canadian Pediatric Society meeting in May of this year. Next, please. So when we think about mental health, we think about promotion, prevention, and intervention. And we think in tiers. So all children and families would benefit from mental health promotion, especially now in what they've gone through with COVID. We all have a role to play in supporting good mental health practices to foster that social emotional growth as well as self-care. Some children and youth may be more at risk for mental health difficulties and would benefit from targeted skill building, bolstering their resources, and protective factors. And then less of them, but few of them will require very targeted interventions for specific mental health disorders and will continue to benefit from the practices. So let's take a look at the next one. So the multi-tiered school-based supports and services, mainly through, I'm talking about Ontario, through the School Mental Health Ontario, does a diagram in this way, and looking at the 3 tiers, prevention, promotion, prevention, and intervention, and really looking at what can we provide at the grassroots level. And unfortunately, like we all know, one of the hardest things is to get help in this area at the grassroots level. We used to have Triple P, we used to have Incredible Years, we used to have parenting programs, all those kind of things, really to the promotion of mental health and prevention. And we've lost a lot of those resources. And we, the Royal We, need to think more about how we can get those back, because that's where we should be spending our time with children and leaving the children who run into more mental health disorders for places like CPRI and others at tertiary level to deal with. Next, please. I'm just going to skip that one. I've said enough about that. So where we are is next steps. Where do we go from here? And I told you a little bit about what I've been working on. What I didn't tell you was that I'm a member upon the steering committee and also the treasurer. So whatever little bit money they have, I'm responsible for that. So lastly, we've got next slide. So I'm going to open for discussion, but you can see him there where he wants to be. I have included resources. So next one. Okay, the references are there. We'll make those available. And like I said, we've come a long way since 2011 when the F words were first introduced. Next slide. And in 2022, just January of this year, the CAN Child Research Team has just published their F words for child development in developmental and child neurology. It's a quick, good read, and it really pulls in the concepts and how we need to be looking at the overall goals, not just diagnoses and specific intervention. Next slide. So that's my thank you to everyone. And I left the time for discussion and questions.
Thank you, Jennifer. That was a fantastic and really thought-provoking talk. And I think the idea of, changing our paradigm and things, and I don't want to sound too highfalutin, but, I think really considering how we think about these things and how far we've moved, as you say, over time is really important. So our first question is from Dr. Goldberg, who has raised his hand. Thank you, Ben. And you should be good to go there, Ben. Oh, you just have to unmute yourself.
Okay. Can you hear me now?
Oh,
Yep.
I can. Nice to hear from you, Ben.
Congratulations, Jennifer.
You're welcome.
I just wanted to say that looking at the accomplishments of Jennifer, particularly in this field of developmental pediatrics, I think that developmental pediatrics has really established itself compared to what I used to call developmental neuropsychiatry. I think developmental neuropsychiatry does not have its own subspecialty as developmental pediatrics. And I think, Jennifer, you've been a leader in this regard. I think the closest that I got to establishing anything about developmental neuropsychiatry was copying the developmental pediatrics consultation fee. And the developmental neuropsychiatry fee is based on the developmental,
Oh.
and it was accepted as that. So I appreciate that. And getting back to your presentation, and of course, CPRI, I think the philosophy of CPRI really embraces everything that you've talked about, and that social work and education, occupational therapy, all of these specialties try to create a therapeutic environment for the inpatient, and of course, to be encouraged in that way. I suppose in psychiatry, your F words are emulated in what we call Axis 4 of the DSM classification. Axis 4 describes, after you give your Axis 1 diagnosis, your Axis 2 personality, then your Axis 4 deals with the whole psychosocial environment. But unfortunately, psychiatry has not caught up to where developmental pediatrics has been in terms of children. So congratulations, and you're still ahead of the pack.
Thank you so much, Ben, and thank you for those words of congratulations. I appreciate that. But I mean, we all think like this. It's not brand new stuff. It's just putting it together in words and making it right out there to talk to children, youth, and their families, and thinking about their overall goals. And it doesn't have to look pretty, as I said. It can still look awkward, but whatever they do, let's encourage in total participation and get those things going.
So Jennifer, there's a question here from Dr. Attendee, first name anonymous.
Oh, okay.
Can you please provide some practical tips for implementing F words in practice? For example, could we use it to structure our assessments, our documentation, our meetings with clients and families, et cetera?
Yes, and yes, and yes. And that's why the resources have been put for free on CanChild website. What you can see on that is resources are there, but they actually give examples of places that are starting to use them and how they use them as part of the way they formulate their discussions with families, how they formulate with youth, how they formulate how they do a dictation, a write-up, everything. It's all there.
And Jennifer, one question that Rhonda Peterson had was, would it be possible to get copies of the slides?
I suppose. For Rhonda, yes. No, I suppose.
So, so will you email that to her directly?
Yeah, I will.
Okay. Other questions and comments that, I think that this is a great way of looking at it, Jennifer, because what I am struck by as a psychiatrist anyway, is especially as a child psychiatrist, we focus so much on people's deficits and areas of weakness. And I think even parents do at times, depending upon their perspective
Yes.
and their background. And I think trying to sort of reframe things as your child is not just a collection of deficits, I think is incredibly important.
Mm-hmm. And not just a collection of not only deficits, not just a collection of diagnoses. How many times do we get that? I mean, I just keep thinking about how many times I get asked to write letters to school, and what they want me to talk about is diagnoses. That's not what I want to talk about.
Absolutely. But along with that, so, that people say, this diagnosis doesn't explain who my son or daughter is. And, and I say, they shouldn't. They're just a description of, well, in psychiatry, behavioral patterns, but they're not meant to be a description of people, that people are so much more than just their symptoms.
Right. And we even within those diagnoses, right, there's such a heterogeneous group of strengths and challenges.
So there are a number of developmental pediatricians with us today, and even some pediatric neonatologists. So Dr. Ogilvie has a question or comment.
Yes.
Jack,
Hi, Jackie.
Oh, I guess you can't see me.
No, sorry.
Yes, sorry.
I see your hand up. I can see your hand.
Great presentation. Thank you so much. And I love all the new resources coming out of CanChild. I've been keeping a close eye on them, but I'd love to hear your thoughts on how we start incorporating this into the next phase of trainees. So trying to make it commonplace for them to put it into their dictations, put it into their assessments. I think, I'm working with one of our residents right now who's interested in helping her colleagues kind of learn this, and she's been wrestling with the best way to do that. So just wonder what conversations maybe have been had at CanChild or Paediatrics, and best places for us to do that.
Okay. Well, first of all, Paediatrics has been collaborating with CanChild, but CanChild has been putting together a series of webinars to be able to try to do like short little webinars about understanding some of these ideas. So that can be used for teaching. Also, I think it would be important to get ourselves on the academic half-day calendar and be able to talk to the residents about them and having them practice thinking like this. And that will get us to that point.
But Jennifer, do you think there is, so I think some organizations, including those that recently just changed their name, I think in the past have talked in their reports, have insisted upon sort of a really positive flavor to things. And maybe it's me as a pessimist, but I think we have to include both the sort of strengths as well as deficits. I mean, what are your thoughts?
Well, and that's the whole point. Yes, you do. But then you take it from, you try to do the strength-based approach, but you still talk about what the challenges are, and then overall what the goals are going to be.
I mean, I think that is a great approach, actually. That's fantastic. So Alexandria Summers had a question. What are some of the next steps that schools can take in moving towards these F words instead of diagnoses?
Well, I think what we need to do as well is that the neat part is that we've collaborated with Paediatrics with, we've collaborated with the Southwest Ontario mental health issues, and that's school-based. And so that's where we're working our way in.
But how do you think the school would have used those kind of that kind of approach?
Well, we've already started at School Mental Health has already started working with teachers on their academic PD days. working on some of these concepts and not getting so stuck on the issues about diagnosis, because again, not every diagnosis the kid's the same. It doesn't explain them. And looking at talking about the holistic child when they're doing the program planning meetings, that's starting to be discussed within that, and trying to formalize that so that we can get to that point. But I mean, it's like anything else. I mean, the whole point of CanChild is knowledge transfer, right? And you know what happens with knowledge transfer, right? It takes a while for things to be incorporated, but you usually have those people who are, you know, passionate about it, and you can give examples. And that's what the other reason about the CanChild website, it really brings forward how people have used it. And it says, can we upload it on our website? They upload to show what other people are doing as well.
Yeah, and I think along with that, you know, what parents will sometimes say is that, you know, all they ever get is bad news from their school, and then things, and how they want to work on reducing things without sort of focusing on the positive. And I think it's important, not just as physicians or allied professionals, but probably for everybody to do that, because I think we also have to think about people's strengths. And I think parents need to hear that also.
Mm-hmm. And how often do we hear, you know, they told my child they can't do this and they can't do that and they can't do this. Well, they can. It just needs to be adapted or modified for the child to be able to do the activity and participate, and having people understand that.
Dr. Ogilvie, you go ahead.
Oh, so your hand's up again. I see you.
It's me again.
Is you okay?
Yep. With the school, and you know, I use the F words, and I'm a strong, you know, I'm on board with the school. I wonder how they'll be able to use them, because so many things are tied to resources. Like they're looking for diagnosis. The message we get over and over again is a diagnosis is a link to a resource, and that's very kind of linear in how those things seem to be distributed in my experience. When we're talking about F words, it's a collection of things, and it's nice because it holds the complexity of the child we're seeing in front of us.
Holistic,
I'm curious how
yes.
they're going to map that onto then advocating for what that child's needs in the school system. And it would be fabulous if somebody could come up with, maybe we need like artificial intelligence to be able to take this F word plus that F word and the outcome of that. And it could be a computer brain could think about different resources that take the human factor out of it in terms of, you know, error that way. But I guess, what are your thoughts on that, Jennifer, around how it could be used?
Yeah, no, that's what people are thinking about, how to do that, because again, both in terms of school-based stuff, but also and in funding, even in the community, as we know. Yep. I mean, so much of it is pinned to the diagnostic. Just think about ASD for a second.
Yep.
I mean, ASD, you get that diagnosis, and then suddenly you're going to get money. But good thing is they're going to needs assessment now, which makes more sense. We just have to see how that pans out. But that's what that is about as well. And then the other part is disability tax credit has come a long, long way. It used to be much more diagnostic based. Now you have to prove where the functional difficulties are, right? Yeah. To be able to do that. So things are moving. They don't move as fast as one would expect, but they are moving. And unfortunately, the school personnel are really stuck at the board level of that issue about resources are based on diagnoses. Mm-hmm. And where they should be, the resources are based on needs, right? And so that non-categorical approach, but it's going to take time.
Yeah. Yeah.
But Jennifer, are they actually based on these, or are they based on the absence of these things?
Yes, I mean, it depends. Well, again, you know, right? Disruptive kids. If you're, if you're a safety issue to yourself or others, right? You're more apt to get a resource, right? Like an EA.
Right. Right. So even though we could try and frame things positive, I think it's still those deficits that are the issue. But I think about them, as you say, in terms of a person's needs and functioning, instead of what their diagnosis is, because I think that sometimes drives diagnoses, so we get the tail wagging the dog sometimes.
Mm-hmm. Well, that's it. I mean, it's the chicken and the egg thing, right? I mean, but that's the point. It should be based on the needs, right?
Yes. So which of those did come first?
I don't know.
Okay.
Can't answer that question. That's one of those, you know.
So I would be really interested in the thoughts of other pediatricians, but also psychiatrists or whoever. What other comments or questions people have for Dr. McLean, who is a great reference and resource for these things? Jennifer, how do you use these in your practice?
Yeah, I mean, when we're sitting down talking with families about, what their goals are, we try to think of it in this language. What we want to do is actually formalize it and call them F words what they are. So the next step, I mean, for example, I've been thinking about this for a while on, for example, Pratt and 1, okay? It is different. I mean, I do different populations of kids I see, but I mean, for Pratt and 1, we get we're very involved in the stretching and the tone management and Botox and Blackfoot and all those kind of things. When, at the end of the day, right, those are important. It's not that they are, but are we addressing the other concerns about the goals of the 6Fs? And, and I think we know about them, we work on them, but we haven't formalized it. And I think that's the steps we need to look at.
Yeah, and think about how we can sort of, I guess, consider the whole person.
Yeah.
Uh,
I mean,
so-
this is not rocket science. I mean, these are all things we know and think of. It's putting it together in, when you're using the language of putting it together when you're discussing goals with families, children, and youth. And at Thames Valley, I've been trying to use it more often when I'm sitting down and talking to parents, what's important to them and their child.
So Dr. Goldberg had a question about do education liaison teachers still transmit and follow up the team's results? So
No.
To my knowledge, I don't even know if we have education liaison people anywhere. So
At the residential units, I think there's one I know of, but nothing for outpatients.
So would you like to compare and contrast services with and without education liaison?
Well, we know that education liaison in the past was a exemplary resource. Really is that connection between finding out what was actually going on at school and translating what we were saying back and coming back to us with it. So it was invaluable. But like everything else, that resource got cut.
Well, and I've thought about this a fair bit, and I think that even if education resources liaison people transmit it, or a psychologist at the school board, or one of the behavior people, I think unfortunately, if we talk to somebody in school or anybody in the community, it's often just that one individual, and that doesn't help the person next year. And I think that that's something we need to work on as a profession, perhaps, is how do we make it so that information that we have about people can be transmitted to other people involved in their care. So for example, providing feedback maybe to families, but giving it to schools in a video format or something like that, so that people in the future would know it as well.
Mm-hmm. Yeah, and then I think that's the point. We're at the point now where virtual is coming a long way. I mean, we've been forced to do it by pandemic, but boy, has it opened the door to be able to see what options we have of being able to do things like this and advocating better than we have in the past.
Yeah, and for sort of continuing services. Jennifer, are there any downsides, do you think, to this approach?
No.
Because if as you said, it's not rocket science, then why haven't we done it previously?
Well, I think we've all done it in various ways, but we just haven't formalized the way of looking at it. It's a paradigm shift, right? I mean, in other parts of medicine, cardiac and seizures, what you do? You treat the seizure, you treat the cardiac problem, right? You have an intervention, you know what to do. But again, not looking at the whole person in terms of things that can affect how they're going to do now and in the future.
No, and it's yeah, I'm just sort of thinking about what that means, because so when you are providing feedback, do you try to follow like the F words? I'm sorry, I find it hard to say that without giggling, but but do you try to follow the sort of the format of the F words and talk about each one of those areas?
Yes, I do. And what I'm trying to do now is to formalize it so I can have resources with tools that parent can take home. That's the part I'm doing next. That is a living document that they can take and they can use that to describe their child as they go to school entry, as they transition. I mean, that's what I'm trying to work on now.
Yeah, because I think it's so important for people to see that, and it's sort of what the long-term goal is. Mm-hmm. As well. I wonder if because Jennifer,
it's a wonderful opportunity for all of us to think about this in every work we do. And like I said, because the resources are free and they're downloadable, loadable off CanChild, if the things you see about ways to improve it or do it better, I mean, they're quite open to giving them feedback, and anything you come up with, they'll put it on the website to share with everybody else.
And I wonder if anybody has any thoughts about how this, because we were talking about developmental population, but how this would sort of expand to other children and adolescents that we see with, or even adults, frankly, with other developmental problems or mental health problems. Because I think is it reasonable to say, Jennifer, that in our field, this is a fairly, I don't want to say niche, but it's perhaps only used in a select group of people?
Well, like I said, it started out with the F words looking at the physical disabilities issues. It started like that, but then realizing that this is applicable to anybody, you know, no matter what age, and just thinking about the whole person in this way. And the issue about Ponda and CanChild working together on the mental health piece is trying to help with the F words about how you would ask the questions around that as they relate to mental health. So giving that some questions that if you're sitting in your family doctor's office, or you're sitting in a community resource office, they can probe it a bit by asking the questions on each of those to get to the place where you need to be.
Okay, are there other questions or comments for Dr. McLean right now?
Got a lot of people at this. I saw 37 at one point.
Yep.
Wow.
I think you have wowed everybody and answered every possible question. So,
So I really suggest people take a look at the CanChild website for the F words. I mean, it's a wonderful resource. There's videos on it. There's tools that they have put together, and other areas have used these tools and across the world, and they're on there as well. So you can see how people are using them.
So, Jennifer, a number of people have said thank you in the chat, and so Dr. Perry, Dr. Sotosanti, Alexandria Summers said thank you, Dr. McLean, from Amber, Anu, Melanie, and herself, and the illustrious Dr. St. Pierre as well. So if people will get, when you leave, you should get an evaluation form mailed to you, emailed rather, and as well as your CPD credit. And if people can take the time to fill out the evaluations, that'd be great. Sometimes we only get one or two, and that doesn't help us really in terms of thinking about future speakers. So it'd be really helpful if people did that. Next month, on March the 9th, Richa Mehta, who is a graduate student in the School of Health Sciences, is going to talk about a research project she's been doing on transition in people with developmental disabilities from into adulthood, and some research that she's been doing using qualitative methods. And I just want to also say that the Developmental Disabilities Annual Continuing Professional Development Afternoon is on March 30th. Registration should be available in the next few days, and it can be done on our website, which is at ddp.uwo.ca. I don't think that's the official or university approved address, but it points to the official address, so just ddp.uwo.ca. Before I thank Jennifer again, I just want to point out that PONDA should not be confused with the POND network, and two groups in the province of Ontario who both work with children and adolescents with neurodevelopmental disorders, and apparently should have spoken to each other before determining their names. But again, thank you, Jennifer. This has been really fantastic, and has really, at least myself, changed the way or at least led me to think about ways I could change things to focus more on sort of outcome and ultimately, I guess, quality of life measures.
Okay, well, thank you to everyone.
Thank you, Jennifer. Take care, everybody. We'll see you in a month.